Hello everyone, today we're going to discuss the National Institutes of Health Stroke Scale, or NIH Stroke Scale, a tool used by healthcare professionals to objectively quantify the impairment caused by a stroke. We try to scone only the acute deficit and trying to exclude the best we can, old deficits, if present. Challenges in the NIH stroke scale scoring are given by the presence of old deficits that the examiner may not know the patient had, or the occurrence of multiple acute strokes. Let's dive in. The first item is level of consciousness in 3 items, A, B, and C. Item A assesses how alert the person is, keenly responsive, easily arousable, difficult to arouse, unarousable. Assigns 0 to 3 points. In item B of the level of consciousness, the patient is asked 2 questions. What month is it? And his or her age. Assigns 0 to 2 points. In item C of the level of consciousness, the patient is given 2 commands. Close and open the eyes and make a fist and open the hand. Assigns 0 to 2 points. Next is best gaze. We test this by having the patient follow your finger or an object in the horizontal plane with their eyes. The score ranges from 0, normal, to 2, forced deviation. Interpret forced eye deviation as a sign of a large territory stroke. Visual assessment involves checking for visual fields and visual neglect, with both eyes open and the score ranges from 0, no visual loss, to 3, bilateral blindness. Facial palsy is assessed by checking for symmetry when the patient shows his or her teeth or smiles and raises eyebrows and closes eyes. The score ranges from 0, normal symmetrical movement, to 3, complete paralysis. Motor upper extremities is assessed separately, right and left. We ask the patient to hold up their upper extremities up at 45 degrees if lying flat, or 90 degrees if sitting, for 10 seconds. The score ranges from 0, no drift, to no movement for each side. Motor lower extremities are assessed with the patient supine and separately right and left. We ask the patient to hold up one lower extremity at 30 degrees, one at a time, for 5 seconds. The score ranges from 0, no drift, to 4, no movement for each side. Limb ataxia is checked by asking the patient to touch their nose and then the examiner's finger. The score ranges from 0, no ataxia, to 2, present in 2 limbs. The ataxia has to be out of proportion to the weakness. This is one of the most misinterpreted portions of the NIH stroke scale. Sensory assessment involves checking for sensation or grimace as response to having felt discomfort to pinprick. Test bilaterally on the face, upper and lower extremities. The score ranges from 0, no sensory loss, to 2, severe or total sensory loss. Only score acute sensory loss. If the patient is unresponsive, then assign a score of 2. Best language is evaluated by asking the patient to describe, verbally or in writing, a picture, read sentences, and identify objects. Score ranges from 0, no aphasia, to 3, severe aphasia. A comatose patient, due to acute stroke, is automatically given a score of 3. Dysarthria is assessed by checking the patient's ability to read or repeat words. The score is either 0, normal, 1 if slurred, and 2 if unintelligible or mute. In intubated patients, this item is untestable. Finally, extinction, also referred to as inattention, neglect, or anosognosia. It is evaluated by checking the patient's ability to pay attention to both sides. Sensation and visual. Observe if the patient orients only to one side. The score ranges from 0, no abnormality, to 2, profound hemi-inattention. That's a brief, succinct and practical overview of the NIH stroke scale. Remember, the NIH stroke scale is a valuable tool for assessing stroke severity and progression. Thanks for watching. For more information and additional training resources and disclaimer, see the description below. Thank you.